Now we come to the functions. These GLA residues which were created during the carboxylation reaction, it is the gamma-carboxylated glutamic acid residues, are the main game changer. These modified glutamates enable proteins to bind calcium ions with high efficiency. These modified glutamates enable proteins to bind to calcium with high affinity, which is absolutely critical for their biological function. To understand this, I'll give you an example of blood coagulation. Here, this vitamin K's most famous and life-saving role exists. Several key coagulation factors are vitamin K dependent proteins. These are factor 2, which is prothrombin, factors 7, 9, and 10. Okay, mnemonic for remembering this is 1792. So this one you can imagine to be 10, and this is 7, and then there is 9, and then there's 2. So you can remember it as a date, 1792. All these are serine proteases, and they are essential for stable clot formation. When these factors are carboxylated, that is what we were discussing, right? Their GLA domains, now GLA is gamma-carboxylated glutamic acid, right? They act as bridges, allowing the proteins to anchor themselves to negatively charged phospholipid surfaces. So it's essential for anchorage. So these phospholipid surfaces are like activated platelets or damaged endothelial cells. They are negatively charged. This precise localization is crucial for forming efficient multi-enzyme complexes that accelerate the clotting cascade by thousands of folds. Without these GLAs, these factors are undercarboxylated, often called PIVKA, which is short for protein induced by vitamin K absence or antagonism. These PIVKAs float freely and they are unable to assemble into clotting machinery. They are free, but they are not useful. This leads to severe clotting disorders, and it is also the basis of warfarin therapy to reduce active clotting factors. Even though this is a disordered condition in a way, but warfarin also leads to formation of PIVKAs, thereby preventing clotting. And you might know that prevention of clotting is quite useful and it's therapeutic for people with quick clot formations and post-MI or cardiovascular disorders. The next function I would like to talk about is in bone metabolism. In bone metabolism, there is something called osteocalcin, which is a protein. It is a bone GLA protein. It is synthesized by osteoblasts, which are considered to be your bone building cells. Osteocalcin is the most abundant non-collagenous protein in bone. Its GLA residues bind to calcium and hydroxyapatite crystals. And this plays a role in bone mineralization, which is potentially regulating crystal growth and maturation. Adequate vitamin K is crucial for healthy bones, so you can understand that by this. Think about India's growing elderly population and the prevalence of osteoporosis. Vitamin K's role here is significant, even in osteoporosis. And the third one is vascular health. In vascular health, there is a protein called MGP or matrix GLA protein. It is found in cartilage and vascular smooth muscle cells. MGP is a potent inhibitor of soft tissue calcification, particularly in arteries. It binds to calcium and prevents its deposition in the arterial walls, thus protecting against atherosclerosis, right? When you study atherosclerosis, you will know how calcium also plays a role in the formation of atherosclerotic plaque. So the MGP protein, which has GLA residues, can just bind these calcium residues and it can reduce the formation of atherosclerosis and also decrease arterial stiffness. Now that we have seen the three roles, the three major functions, we have seen the three major functions of vitamin K. The first one was in clotting, right? With the formation of gamma-carboxylated glutamic acid residues, bridges can be formed and anchorage can occur properly and clot formation can occur properly. PIVKAs are undercarboxylated proteins and warfarin is being used here to exploit that to prevent clotting, which can be pretty useful in highly coagulable states. Then in bone metabolism, osteocalcin is the protein with GLA residues and it binds to calcium and hydroxyapatite and stimulates mineralization of the bone. And finally, in vascular health, the MGP protein, binds to calcium and it reduces soft tissue calcification and atherosclerosis. I want to now give you a mnemonic for vitamin K dependent factors. Mnemonic is, actually I've already given this to you. It is 1792, or you can also remember it as 1972. Whichever you feel like remembering, you can remember. These are all vitamin K dependent clotting factors. The next mnemonic is OMG, Osteocalcin, matrix, GLA protein. So these OMG are the extrahepatic functions of vitamin K. Then we come to the deficiency. When the vitamin K is deficient or there is some kind of disorder, it is either missing or it is being inhibited. If either of these occur, then there is deficiency and it can lead to severe consequences. But first, let's see the causes. What can be the causes according to you? So the first thing which should come to your mind is during the absorption. So malabsorption syndromes. Example, impaired fat absorption is seen in cystic fibrosis, celiac disease, chronic pancreatitis, inflammatory bowel disease, or obstructive jaundice. This can lead to vitamin K deficiency. If you can't absorb fat, you can't absorb fat-soluble vitamin. The next is liver disease. So we know that it is the main processing part as well as the storage part of vitamin K, since the liver is central to synthesizing clotting factors. So severe liver damage can impair vitamin K metabolism and protein synthesis, leading to coagulopathies. Then the third one is broad spectrum antibiotics. Why do you think these are the causative agents? Because they can wipe out your beneficial gut bacteria that produce vitamin K2, especially during prolonged use. Then we have dietary deficiency or insufficiency. While this is a bit less common in adults due to gut bacterial production and dietary intake, it can occur in very restrictive diets. This has to be kept in mind for newborns who have sterile guts, so there's no vitamin K2 production, and there is limited placental transfer of vitamin K from mother. So low vitamin K content is also present in breast milk, and they have immature liver function. So it is common in newborns and infants. This is why every newborn in India receives a prophylactic intramuscular injection of vitamin K at birth to prevent life-threatening intracranial hemorrhage. This is a public health triumph. So as we are talking about the deficiency, let's come to the clinical manifestations. The first one, which is hemorrhage, which is excessive bleeding. So easy bruising, epistaxis, which is nosebleeds, gum bleeding, hematuria, which is blood in urine, and dark stools from GI bleeding, and most dangerously, intracranial hemorrhage, especially in infants. These are the very crucial clinical manifestations. Then there is impaired bone health. Long-term deficiency can contribute to reduced bone mineral density and increase fracture risk, though this is less acutely dramatic than bleeding. Then vascular. This is potentially accelerated arterial calcification over time. Lastly, we come to the diagnosis. So the diagnosis is number one by something called PT, or prolonged prothrombin time. This is the most sensitive test for vitamin K, as factor 7 has the shortest half-life and it is the first to be affected. Then the second one is the measurement of PIVKAs. So what were PIVKAs? If you remember, they were proteins induced by vitamin K absence or antagonism. These are under-carboxylated clotting factors. So these are also being measured nowadays. Then lastly, there is a response to vitamin K administration. A rapid correction of PT after vitamin K injection confirms the diagnosis. Finally, let's end this topic with a high yield summary like always. So what we learned is there are various forms of vitamin K, right? There's K1, K2 and K3. Which one was the synthetic form? Right, K3. It is not being used now. Then we learned about absorption. So what did we learn there? We learned that it is fat soluble. It requires bile salts. It is transported via chylomicrons and then LDL or VLDL, right? Then we learned about the mechanism where it is essential cofactor for gamma-glutamyl carboxylase for converting glutamic acid residues to gamma-carboxylate glutamic acid residues. These are valuable because they bind to calcium. And we have seen various places where they have a role. Where did we see all this? We saw the role in coagulation. Then we saw a role in bone health. And then we saw a role in vascular health. Then finally, we talked about the deficiency. We talked about the causes and the various clinical manifestations and how it is crucial for newborns. We talked about the various reasons as well. So we come to the end of this topic of vitamin K, and I hope you understand the value of vitamin K now, and hope you use this to bring into your practice and it helps you in your exams, because this is kind of like an underdog which is being researched more nowadays, and scientists are finding all kinds of places where this is highly valuable as a vitamin. Thank you for listening and hope this video helps you, and hope to see you soon in the next video.